Hello, good afternoon. We're gonna get started here in a minute. Welcome, everybody. We're just gonna give it a minute to let people log on and get situated. Welcome to the webinar. All right, as people get on here, we're gonna get going on the introduction. Welcome to this webinar. It's called What Works in Clinical Supervision, a review of 21 supervision strategies, hosted in partnership with the Center for Advanced Studies in Child Welfare, also known as CASHU. We're a research and training center located in the School of Social Work at the University of Minnesota, and we partner with faculty to translate research to practice and specifically to child welfare issues. So I'm Stacy Geringer, the Director of Outreach at CASHU, and please feel free to chat me if you need anything throughout the webinar. Some quick housekeeping. This webinar is being recorded and will be sent out to all registrants. Mimi will also provide a copy of her PowerPoint and we'll email that out to folks. Please, we encourage you to use the Q&A function throughout this webinar, and the chat is also open. We'll get to as many questions as we're able to. There will be a brief evaluation that will pop up on your screen right when the webinar ends. So please feel free to fill that out. And for those of you who are interested in receiving a CEU, a social work CEU, you'll need to stay on for the entire webinar and then complete that evaluation. Mimi will present for about 50 minutes, and there'll be about 5-10 minutes at the end for audience Q&A, though you're welcome to ask questions throughout, and she'll likely be able to pause and address questions if needed. And if you need any accommodations during the webinar, please feel free to chat me or the CASHU name on the Zoom. So I'd like to introduce Dr. Mimi Choy-Brown, who will host this virtual web training. She's an assistant professor at the University of Minnesota with over a decade of practice experience. Her scholarship focuses on clinical supervision, serious mental illness, implementation science, and developing strategies to improve and sustain high quality community mental health services. She also hosted the Heart of Supervision podcast, which was a collaboration with CASHU. So we're really excited to be working together again. I will let Mimi take it from here.
Sure. Thank you so much. And thank you so much to CASHU for inviting me to have this opportunity to meet with all of you. I really encourage you all to put questions in the chat as they come to you, in the Q&A. And if we could just start off just to get a sense of the folks in the room, in the chat, if you want to list whether or not you're a supervisor and maybe how new you are to your supervisory position, if you're just thinking about becoming a supervisor, or if you're a seasoned supervisor, so we kind of get a sense of who's in the room, so to speak. That would be helpful. So I first just want to, and it's going to, the title of this talk is What Works in Clinical Supervision, a review of 21 supervision strategies. And both myself and Laura Saltani, who is my colleague, worked on this presentation for today. And please feel free, And I also want to acknowledge that this work is based on a paper that we wrote that I'm happy to share with anybody who's interested. And so I just want to acknowledge my colleagues who worked on this systematic review. It was a tremendous amount of work. And the researchers who generously shared their supervision protocols and their published work. And so for all of those supervision researchers, just want to acknowledge them for doing this work. So I'm just looking at the chat a little bit here, and it looks like we've got a range of folks that have tons of experience in this area, and some that are brand new and some just in the middle. So this is perfect, and glad to have this community together for our discussion today. So the plan for the next 45 minutes or so is that I'm going to talk about what we found in terms of those supervision strategies that have some evidence that they're going to work to help supervisees learn new practices and use new practices in their work. And this work primarily focuses in community mental health settings. That's where we were looking at mental health settings. So then we also want to make sure we're discussing these findings within the context of scholarship and practice in child welfare. And so those are the two main goals for us today. So first, this is going to be things that all of you are aware of already, I'm sure, but some of the challenges facing the child welfare system is that we have this really high turnover rate of at least 22% of child welfare workers are turning over every year. And folks are really sticking around just under 2 years on average. Most often, actually the median, so it's the most often number of years that folks are sticking around is less than 2 years. But supervisors are also but a little bit less turning over at a rate of 20%. But the cost to our systems, not only in our time, but in actual financial resources, is $54,000 every time we have to replace a new worker. And we see some really significant racial disparities and disproportionality in the representativeness of the workforce at all levels of the child welfare system. So these are really significant workforce challenges facing child welfare. So some of that, when we looked in the literature, just trying to figure out, and I know in practice settings, many of you will have experienced this, is that there are some things that are helpful for sustaining the workforce. We know that, some of the top contributors are stress, emotional exhaustion, and any concerns around safety. But some of the top things that help this turnover is sort of that organizational context and commitment, satisfaction, as well as perceptions of the organization, climate and culture, and perceptions of kind of fairness and concern about well-being. And supervisors, some of my work with colleagues has shown that supervisors are often the ones who are crafting that perception of the organizational culture and climate and have a really significant influence on it. And supervision has been associated in multiple studies in supporting workers and really mitigating, and that means sort of reducing staff burnout, improving their confidence in their work, their self-efficacy, promoting sort of that feeling of psychological, emotional, and physical safety in the context of their work, and also kind of in the context of supervision, really promoting that professional development and growth. And we also see some, lesser focus, but some evidence does exist on the impact of supervision for outcomes of families, the role of supervision in supporting family safety, supporting workers' ethical decision-making through reducing bias. But we really want more research around supervision's impact on family outcomes. So this is still an area of growing interest of mine and other supervision researchers. So, we're seeing for all of these reasons that supervision is a resource in child welfare. That's why we're sort of talking about it today. And that's why I focus on it as a resource. The goal is to really ensure competent delivery of care through providing on-site responsive support and professional development for supervisees. And you can see this Venn diagram here that in the social work literature, we really think about supervision as having these three main functions: the administrative, the supportive, and the educational. Within this kind of universally included structural support for child welfare practice, it's often state mandated for many of us for individual and facility licensure. And I would argue is very well positioned to influence the experiences that families have of services, because you all are, overseeing the workflow. You're there longer than direct service providers, and you're having really often daily interactions with providers. And of course, it's also the signature of pedagogy among all the allied mental health professionals, and particularly within social work. Just checking the chat. Okay. So common challenges that we see in child welfare in terms of clinical supervision is administrative responsibilities and requirements sort of dominating the available supervision time. So workers are often sharing in our research and others in the literature, really a lack of time to talk about sort of their emotional and reflections, their emotional responses and critical reflections of what's going on in their work with families and children. And limited time to help make decisions. So often supervisors feel pressure instead of kind of eliciting reflection and giving opportunities for learning and experiential learning. They're often telling workers what to do just for expedience. And part of this is a lack of support and training for supervisors. Part of it is also the systemic pressure that supervisors are under. But another component of it is really missed opportunities, I think, for worker and supervisor development and sustainability within the child welfare workforce. So here you can see our Venn diagram. We've broadened the bubble of administrative, and really we've got this supportive function that we're seeing and educational. Curious to see, for folks in the chat, is this resonating with your practice experience? Are you seeing administration and administrative supervision really dominating your time? Go ahead and share in the chat. So we know that all of you are in, I can't actually see this now. Oh, there we go. So yeah, so thank you for sharing that. You really have to be intentional and ensure that you can get that balance. And so I really appreciate that. And I have this slide here because it really does feel like in these high pace, high stress and low resource settings, it's really a juggling act of trying to figure it out. And so I was really curious, and this study kind of comes out of this, like, what are the supervision practice elements that have evidence of improving implementation of a new treatment or a new practice, or influencing family experiences or patient experiences with their interactions with providers, especially if, and we have really limited time, what are the things that we really need to do in order to help our staff and our supervisees kind of integrate this kind of reflection and new learning. And also, that's a great point. We're thinking about, like, there are some different models. So I'm really thinking here about supervision where it's all together, but I know some places are separating those two things, the administrative and the clinical and professional development, separately. And so that's one way of thinking about it too. So thanks for sharing that. Oops. Okay. So the second question we had is sort of, what is the nature of these kind of supervision practice elements, and what's the prevalence of those practice elements across studies? So there's some of this work that I'm going to talk about today that's sort of really researchy. And so I'm happy to kind of move quickly through that, and then I'll pause and see if anybody has any questions about the methods and sort of what we found. But then I will dig into sort of practice examples of how you could use these different strategies, just to give you a little orientation. So one of the ways we were thinking about this is that, how could we look at, there's not a lot of research that looks at test specific supervision strategies to see the impact of them. And so we were curious, if we look at clinical trials of mental health treatment, again, I'm a mental health services researcher, so that's where this sort of work is embedded within. If you look at clinical trials for treatments, and when I say treatments, I mean, like motivational interviewing or cognitive behavioral therapy or multisystemic therapy, functional family therapy was another one represented in this group that we're going to see. But really, when they're doing those clinical trials, it's really the treatment protocol, which is an important aspect of it, but many of them also include clinical supervision in order to, within the context of the trial, to get high fidelity to even really test their treatment. And so what we were really curious about is, what of these studies have have taken this treatment protocol and then looked at the independent effect of clinical supervision, because we think it has this really high potential as a low cost, high yield intervention point. And so there are these gaps in knowledge. There's no real consolidation of evidence around any given model of supervision. I think so no model is like clearly the model. There's no comparison of different clinical supervision strategies in community health settings like child welfare versus what's been tested in clinical trials. And so without this consolidation of what they actually do, it's really hard for us to compare it. And so it really remains unknown which strategies are both necessary and what do we not have to worry about anymore, because we have such limited time in order to support learning and use of kind of evidence-based care or high quality care. So there's two different phases that we did to kind of figure this out. We had this phase 1 and phase 2, which I'll talk about. So this phase 1, this is just giving you a sense of where did we get these. We wanted to look at, one, were they treatments that already had really strong evidence that the treatment itself worked? So all the examples that I gave you, I think the most child welfare applicable are, multisystemic therapy and functional family therapy, though of course cognitive behavioral therapy and motivational interviewing were also in there and I know are provided. And then we wanted to look at, so that's this first hurdle. The next hurdle is, okay, so is there evidence that they have tested these supervision protocols to see if they have impact on how providers learn it and use it, and maybe how clients also experience the care that they're and their own kind of clinical outcomes. And so we got to these 13 supervision protocols. So here's some of the manuals. So we wrote to all of the researchers. We asked them for their manuals, and we coded all of the manuals and did sort of a validated distillation process. And again, I'm happy to talk about it, but that's how we sort of came up with this taxonomy, which is like a classification system for all the different kind of micro skills or strategies, or kind of we're calling supervision practice elements that make up these different protocols. So we can see for many supervisors in community mental health and in child welfare, I think, are overseeing lots of different kinds of things. And so what are the things across all of these that we can really start to understand are most salient and most prevalent? So a little bit about, well, let me pause there actually, before I launch into telling you a little bit about the studies that were included in this sample. Does anybody have any questions about the methods or how I got to this group of protocols for us to review? Well, if anything comes up and I'm going to keep talking a little bit as you take time to write in the chat or the Q&A, but please let me know. And Stacey, interrupt me if there's a question about the methods. So a little bit about these is 77% of them experimentally manipulated supervision. So they randomized folks to different kinds of supervision conditions. I mentioned all of the different, the only one I didn't mention was dialectical behavior therapy, which was also included in terms of the EBTs that were tested. In most of these studies, the supervisor was not a supervisor using like in a workplace-based supervision, but a supervisor who is also an expert in whatever intervention was being tested. There's a bunch of different settings, palliative care, substance use, mental health settings in like both university-based like academic health centers and also training centers and community settings, and across 5 different countries. So we had United States, Sweden, Germany, Russia, and Ukraine. And many of them were testing the effect of supervision on, these implementation outcomes, which were adoption. Did they get supervisees to use it? Did they use it as it was intended to be used? And how much did it cost to use supervision to do that? And then also we saw clinical outcomes in 5 of the studies, which included youth externalizing behaviors, as well as substance use. So a little bit more about the studies before I tell you more about the actual strategies themselves. So I just wanted to highlight that, about half of them used only individual supervision. Some of them, a very small sliver, the gray here, 15% used only a group format. And then we see in the green, 15% used group plus individual, which is really different. And then we also see the 23% used group or individual. So depending on whether or not they kind of included both when they were testing it. And you can see over here too, that in terms of the amount of time that they spent. So if you're starting, the reason we wanted to look at this is like, what is feasible and pragmatic within our community settings? And some of these we're using supervision was 90 minutes per day, including prep time. And then all the way, that was sort of the heavy end, all the way to just 30 minutes every 3 weeks that saw effects. And the duration of it ranged from just 3 weeks to 18 months. So it was a really broad range of both the exposure to supervision and the intensity of it. And so here is sort of what we found after kind of going through and doing coding of all the different protocols. We broke them up into these 5 strategies, or 5 kind of domains of strategies. You have here sort of the learning strategies, which we'll talk a little bit about. I'm not going to present today on the individual use of structured tools, though I left the slides in the deck so you can look at them, but I think they're pretty self-explanatory. So I'll just highlight a few, using learning plans or goals with your supervisees, kind of discussing what some of their goals might be in terms of professional development, setting agendas, using tools that actually kind of structure and guide the teaching, didactic teaching, or kind of feedback. And then also assigning additional training and learning. So this, this might be a good area for you. You might say to a supervisee, this might be a good area for you to get some additional support. Why don't you go take this training? Here's where it is, etc. We also have a section here on data gathering. So the different ways in which supervision gather information about their supervisee's practice, and then how they provide feedback, and then these relational strategies. So I'm going to go into each of these individually fairly quickly, but I'm happy to ask or answer any questions in the Q&A, or if things come up as you see, hopefully they just sort of jog ideas. Maybe some of it will validate what you're already doing in supervision or you already want to be doing. And then maybe there'll also be some ideas for things that you could try. So here are some learning strategies. So behavior rehearsal. This is sort of using role play. Clinician or the supervisee is actively practicing a skill during the supervision session, and the supervisee is playing the role of the therapist or, kind of practitioner in supervision, and the supervisor is playing the role of the family or child. So supervisor might say, let's try it. I'll pretend to be the kid. And then as the kid, they say, but it's too hard. I can't talk about what happened. And then the clinician will play the clinician role and respond, and kind of working that out in the context of supervision. Elicitation is another one where supervisors use questions to encourage thinking or elicit the thinking, planning about a subset, planning for the next kind of session, and kind of using questions to promote that, and also evaluating kind of retrospectively thinking about how did that past interaction go. So supervisor might say something like, he's really blaming himself for what happened. Given what you know, what might be the possible views of the situation from the child's perspective? And here's another one. Supervisor might say something like, he's really blaming himself for what happened. So same kind of prompt here, but what might this mean and why does that matter? And those are some of the questions we pulled also. So elicitation, I think, has some overlap with reflective supervision. And so I put in some examples of reflective supervision questions here, which is the second example. Modeling, so a supervisor kind of enacts or demonstrates a specific skill or method of delivering a treatment component or a practice component during the session. So a supervisor might say, in the context of supervision, you might say something like, could there be anything that has happened in your past that guides how you interact with your daughter? Oh, and I would just add, so in this also, you might even play out where the clinician is acting as the caregiver or the parent, so that they can sort of present the things that the caregiver is saying and see what their supervisor might say instead. There's also didactic instruction. So kind of like what I'm doing right now, just kind of delivering information or explaining something to the supervisee, kind of more of a lecture style. And so, supervisor might say something like, there's research showing that sometimes PTSD symptoms can sound like hallucinations, for example, thinking they can hear the offender talking. Parallel process to the clinical practice skill. So in this one, supervisors, the protocols actually directed supervisors to use a similar kind of philosophy or structure or concepts within the supervision process that mirror what the supervisee will be doing in the interactions they're having with a family or a child. And so, for example, here, if part of the intervention was really to think about supervisees' cognitions and connect them with behavior, or kind of connecting thoughts with behavior, then the supervisor might be doing that also in the context of their supervision. So they might say something like, what might some of your fear thoughts be about approaching this topic with your client? So when we say parallel process here to the clinical practice skill, I'm not saying that, in supervision, you would dig into the same kinds of things about the supervisee that are private and kind of within their own families, but that you would be modeling a similar kind of philosophy or structure, like focusing on cognition, but all related to the work, which would be a big difference. All right, I'm going to pause here and see if there are any questions about any of those learning strategies before I move on to data gathering. All right. One thing that's come up in other talks when I've talked about this is, and one thing I just wanted to highlight is sort of what are the conditions that you use these kinds of learning strategies. And I think one of the things that I would highlight is that not everybody is ready to learn at any given time. And so really tuning in to kind of where your supervisee is before you say launch into a role play. If they're coming back really dysregulated about, a really intense emotional experience with a family, that might not be the time to do a learning strategy. And so really paying attention to when these might be most useful, I think is an important kind of beginning point before you launch. Like with anybody, not everybody's motivated or in the right kind of stage of change to, and in the right space to start learning, just like any family or child or adult person. All right, so I'm moving into data gathering strategies. So one of the things we saw was really reviewing actual practice. So that means that the supervisor observed either live, like they were in vivo with the person, or they saw a recording of the supervisee's interactions with the client. And so a supervisor using that in the context of supervision might say something like, watching part of your session, I noticed that you did most of the talking throughout the session. Tell me why that might not be the most effective way to change the mother's behavior with her child. Fidelity assessment, this one is, using a standardized tool when you're looking at adherence to a particular practice, whether or not they're delivering whatever the practice or model might be as it was intended. And discussing that in supervision. So this is an example for trauma-focused cognitive behavioral therapy, but So the supervisor might say, as you know, practice is an acronym for the components of TFCBT. Tell me which components you've completed and which one you're on now. So information gathering, this one tends to be pretty widely used, where a supervisor is sort of gathering information in the context of supervision about a client, a past session, or about kind of trying to assess a supervisee's kind of skill level. And so a supervisor might say something like, can you share with me about the discussion you had about Sarah's motivation to change during your last meeting? And if you're able to elicit any self-motivational statements, reasons why they want to change. Progress note review. This one is, when a supervisor reviews the progress notes prior to meeting with the clinician, or during the supervision session. So this example is supervisor says, let's look at your case note for the last session. And the thing I'd highlight about this is that, this progress note review focus is to the extent to which it can help you understand what the interactions are like with between the supervisee and families or kids or parents, caregivers. Rather than kind of making sure that they're completing their notes effectively. I think that's the spirit of this strategy is to really get insight into the interactions. This one is also another way of gathering information about those interactions. And to the extent that it's used, some settings, and particularly in these settings, kind of repeated use of a standardized assessment tool to measure if, a family's symptoms, functioning, or some other kind of process that you're tracking, or how things are changing over time in order to examine, like, is our intervention really working? So even just safety assessment could be something that you're really thinking about. So this example is from mental health, where, we're looking at maybe a depression screener, and a supervisor says, so let's think about this depression score, which is at a 13. What was his score when you started working with him? And really kind of just using it as another data point to really understand how things are going. So I'll go ahead and pause there. So those are some of the data gathering strategies before I move on to feedback. Any thoughts or questions? So here we are. This is feedback. This is sort of a shorter group. There weren't as many kind of elements directing feedback. So providing clinical suggestions, this is a pretty common one where a supervisor will just go ahead and give an idea, a suggestion or direction to a supervisee about what to do. So a supervisor might say, you mentioned that the last session, the mom asked about what was going to happen in court. I might have walked through the process or given her ideas for how to find out more information. So it's just really kind of going ahead and giving a clinical suggestion. So when we saw in the literature, when we looked in the child welfare practice literature, this was a common strategy that was used, especially in the context of limited time. And then also supervisor feedback tools. So really having specific documents or tools to guide, feedback about specific elements to clinicians. So for example, a supervisor might say, let's take a look at this motivational interviewing rating worksheet and go over the skill level comments that they might have. I think also we see, something like this often with kind of annual evaluations, or if you have quarterly evaluations within your setting, really guiding what you're supposed to be giving feedback on. So this last group is the relational strategies that we saw in these supervision protocols. And again, all these protocols had a positive impact on supervisees and different constellation kind of groupings of these different strategies, but just to give you a sense of sort of what was in protocols that worked. So supportive listening. So supervisors are making statements that are reflecting, validating, acknowledging, or praising a clinician. I think this is one that I think often comes most naturally to folks or is most comfortable coming out of, especially clinicians promoted to supervisory positions. So this is a simple example, but supervisor, that sounds like a frustrating situation. Elicitation of feedback on supervision. So this one is a relational strategy, really to get a sense of like, how are things going just in the context of our supervision. So really prompting that feedback from supervisees. Can you all still hear me? Hopefully, yes.
Yep, we can hear you, Mimi. You're doing great.
Stacy, can you hear me?
Yep, we can hear you.
Okay, perfect.
Yep, you're good.
There's some technical stuff happening in my house. Okay. So supervisory. So here's an example here. What's been missing in our discussion today? What would be helpful for us to discuss is just kind of getting feedback on the process and really making sure that you're integrating those opportunities so you can hear about what's working and what's not. Really tuning in to that supervisory alliance. So really focusing on building rapport with the supervisee, what's going on with them, what are the needs, like what information are you getting from the supervisee in their body language and their behavior and the content of what they're saying is really a critical strategy that's used across supervision, across allied professions and within different contexts. So a supervisor might say something like, after that crisis last week, I noticed you've been quieter in the office. How have you been doing at work? And this last one is attention to power. So this is really when a supervisor attends to is really thinking about and intentionally bringing in attention to the hierarchical power dynamic between the supervisor and supervisee, so that the supervisor may have sort of a gatekeeping role. They may oversee the person's kind of job status. And so thinking about that kind of formal power dynamic, but also thinking about kind of social location differences and attending to racism, oppression, and colonization that might be happening within the supervision relationship, and opportunities to talk about it within supervision about what's happening in their clinical or interactions with families. And so a supervisor might say something like, I'm wondering how racism might be playing a role in how this interaction is being interpreted. So then that second research question that we had was really thinking about the frequency. So how often were these things used? And we saw a review of actual practice was used in almost all of them. So this is one that was really consistent. And so you see these kind of top ones that were most consistent across. We see, reviewing practice and, gathering really a lot of information. And some of these tools for, sorry, there's some stuff happening here. And also different tools for supervisors to provide feedback. We also see here that less often we're seeing kind of symptom monitoring or kind of attending to the alliance. They really didn't acknowledge that or promote that more often. And attention to power is also quite low, and only 2 really kind of attended or kind of specifically directed supervisors to think about that in the context of their supervision. So just to highlight some notable inclusion and exclusion of strategies from this work, we really think that it adds to the evidence of using these active learning strategies, which have a kind of growing amount of literature and evidence. That's really using those opportunities for role play and modeling to really just practice and actively learn within the context of supervision. We also think it adds to the evidence for the importance of auditing practice. So that is really getting a sense of what the interactions between supervisees and families and kids is like. and being able to inform that kind of audit or those kind of observations, really informing the feedback that you're giving to folks. And I have some thoughts on ways to integrate that, but in community-based settings, but I think that that was really critical. We thought it was pretty notable that symptom monitoring was missing, in particular in the context of community mental health, because there's such abundant support, such abundant evidence supporting how useful it is. And so it could be a real missed opportunity. We also thought that it added to the evidence of relational strategies and really the importance of them. And again, another really big missing one we thought was this attention to power. And particularly because the frame of the study was to think about implementation of evidence-based treatment. And so there's a real risk there about harmful, potential for harmful effects, particularly in marginalized communities. And so that is also really is consistent with really infrequent use of this strategy within observed workplace-based supervision. So this again is just to give you a sense of, this is some data from community mental health settings, just to give you a sense that we do see this supportive listening, information gathering, and didactic instruction happening the most. This gives you, on the left here, this gives you a sense of who drives it. Like, does the supervisor drive the differences, or does the clinician? So you can see here that different supervisors use information gathering differently, whereas didactic instruction, who the clinician is sort of changes it the most. We also see this kind of active learning and maybe using symptom monitoring really happening kind of to a lesser extent and really at a low intensity within kind of community settings. And again, the one that's used the most across all the different protocols is really available the least within community mental health settings in particular, and that's reviewing actual practice. So then if we look at what's available within the child welfare literature, we've highlighted here in green, this is Laura Sultani, my colleague, did this particular work, and really thinking about, these are the ones that we're seeing actively being used in the child welfare literature in green. And you see some of the things that are less focused on and maybe missed opportunities are the kind of use of a role play as a learning strategy and some of these data gathering strategies, but everything else we're really seeing in the literature. So we do think, even though this is in community mental health, that it might have some applications within child welfare. So worthy of all of your time. That's why we thought it would be useful today. And we also, when we looked in the child welfare literature, found some additional strategies that weren't captured in ours that we thought were important to highlight for you all today. Other strategies that folks are seeing and testing and hearing about. So the use of peer supervision. So that is supervisees getting together and kind of talking about what's going on in their interactions. And kind of providing that mutual aid support around what their work is. Identifying external clinical supervisors, both for supervisors and also for supervisees. And I think one participant today highlighted that that's already happening in their workplace. And so that's another great opportunity to kind of make sure that there's kind of time for it. Really focusing in on trauma-informed approaches within supervision, to some extent that overlap and some that don't, with what we have included here. We also have supervision for supervisors. So really providing that opportunity for, whether it's internal or external, really making sure that that's a resource for supervisors as they learn this totally new set, I would argue, totally new set of skills to be a supervisor. Just because many supervisors, I think, are moving into their positions because they're very competent and efficient clinicians. And so they move into these supervisory roles, but it is a new set of skills and a worthy one of investment. So the other thing I know that's gotten a lot of information, a lot of traction within child welfare is really thinking about reflective supervision. And so I just wanted to pause here. I'm not going to do a deep dive on this at this point, but I just wanted to highlight, when we think about reflective supervision, and how it might overlap with some of the things that we've been talking about today. So what is it? It's often supervision that has, some regularity to it, that you can count on the time. There's reflection on feelings, thoughts, and observations. So a lot of this, I think, could be overlapping, and really a collaborative relationship with attention to sharing power. So really thinking about really intentionally that collaborative relationship. And it has been associated with some important kind of supervisee outcomes. Most importantly, I think kind of the development of reflective capacity, and really thinking about kind of thoughtful decision making and reflecting on bias. And here we see sort of some of the overlap. I think the information gathering strategies utilized within here, parallel process, obviously the alliance and power within supervision. And I think in the context of elicitation is where you're going to see some of those really key reflective questions that you can integrate. Some additional features might be kind of the professional use of self, and holding the baby in mind. And so if you're interested in sort of kind of some more information about reflective supervision resources, because I know that that has been a focus within child welfare, I just wanted to highlight some of these. And I think Stacy might put these into the chat. But if you wanted to learn more, we interviewed Dr. Mavison, who's from the SEED Center, about reflective supervision. And so I just wanted to link to the kind of Heart of Supervision podcast that we did that talks about various aspects of supervision. If you're excited to hear more, there are great interviews in there. There's also this Cashew has another kind of reflective supervision and consultation for child welfare workers resources here, and then also some links to resources from SEED about reflective supervision, should you want to learn more about that particular practice. So kind of takeaways and things to think about from this study and things that we've talked about today. As I said at the beginning, I really think the role that many of you and close to all of you have in providing clinical supervision may just be that keystone, that piece that holds it all together for high quality practice, and really how to integrate what we hope and intend to happen, and how is that really going to look like day to day for this supervisee, for this family. How can they apply what the best practice and your expertise in the context that they're in, promoting that awareness and learning of how to do that and their expertise. And I really think it can be an amazing resource for accounting for structural disadvantage for people who carry marginalized racial identities or racialized identities. So supervision, I think, is really where the rubber meets the road between how practice is intended and how it's delivered, as I mentioned, with any given context, with any particular person, and in collaboration with a family. And I'm really curious to keep learning about, under what conditions within child welfare these strategies could be effective, and how we can harness sort of all of the knowledge for many of you on the call with decades of experience of how to do this. I think we've underutilized all of the things you've figured out and spread them. And so how can we design supports within the constraints of all of your workplaces that can really give you these actionable strategies that you can use today with folks in the supervision time that you do have available. So those are some of my future questions and conclusions. I do want to thank you all for taking the time out today to spend some time with me, and all of the work that you're doing to bring hope and humanity to the really difficult work that you do. Just to highlight, don't forget to complete the evaluation. We're leaving some extra time here, so you'll have time even in the context of what you've already budgeted for today. And if anybody has questions or comments, this is my email address, and we also have about 10 minutes. If folks want to pose some questions, I'm happy to to answer them today if you want to put them in the Q&A or the chat.
Thank you, Mimi. We'll give folks a minute or two here. If anybody has any questions that they'd like to ask Dr. Choy-Brown right now, we have a few minutes. And certainly if folks don't have questions or don't want to ask them publicly, Mimi's happy to field them via email as well. So we'll give it one more minute here.
I just put my email in the chat also in case people need it.
I'm going to give it a few more seconds. I know sometimes people come up with questions, and if not, no worries. It looks like Michelle does have a question. Mimi, do you see that?
Yeah, so the question is, when using clinical suggestions, is it best practice to ask the supervisee if they're open to the suggestion? You know, that's a really good question, Michelle, and sort of thinking about, you know, really when you're kind of using any given supervision strategy, like, what am I trying to get across? What is the goal of this? Am I, is this supervisee in a place where they can hear this suggestion? And whether or not it's best practice, I do think that having a sense and tuning in to, and maybe that is like a direct ask, you know, I have an idea of something that you could do here, and going ahead and sharing it with them. I do think that using clinical suggestions, particularly, sometimes people think about it in terms of the developmental stage of the supervisee. So sometimes if you're doing elicitation and you're trying to elicit kind of what to do, supervisees, sometimes it can really build anxiety because they're like, especially earlier in their career, because they just don't know what to do. And so clinical suggestions can sometimes get people started. And so I think your suggestion, or you're thinking about, maybe I should just check in with them to see if if a suggestion might be helpful. I think that is a good strategy to use. There's another question about, you know, that says, I think sometimes supervisors think they need, oh, and let me know, Michelle, if that doesn't answer your question or if you have any follow-ups. I think sometimes supervisees think they need to be the expert or have all the answers. How do you think embodying humility might be related to some of these effective strategies? Is humility mentioned by folks much in the literature? Oh, thank you so much for this question. This is a really, really important one. I did some of my work. I was doing observations of clinical supervision and interviews with supervisees and supervisors. And this idea of humility, I think, was really, really important, particularly when I think about implementation efforts. So when you're trying to change a supervisee, like everybody's practice all at once. And I found that actually using modeling for the humility, like it's okay to make mistakes. It's okay to not know everything, and really modeling for folks what curiosity and sort of what making mistakes looks like, what it looks like to get feedback from supervisees can help flatten that hierarchy, and really thinking about a collaborative supervisory dynamic. And it also can kind of foster that practicing together. Like, we're in this together. We're all practicing. We're all learning. I think also the other piece, so modeling that kind of humility that you're talking about, I think is another really important skill, is particularly with clinical care or interactions with families. Like, we aren't always the expert. We bring a certain expertise, and that's really important, but that doesn't mean we don't have things to learn, particularly about families or about particular systems, and particularly about supervisees and how they function in their interaction. So I think it has a lot to do with it. I'm really glad that you brought that up. Is it mentioned in the literature? I would say that, you know, it's certainly in the context of some of my work, and I don't know if I could say how much it's mentioned across the literature, but it's a really, really good question. The other thing I would say when it touches on these strategies, so I gave you examples of experiential learning and being able to model what it's like to learn as a supervisor. Also flattening that power dynamic. So really thinking about it in the context of power, and really just being aware of your limits as a supervisor. You can't know everything, and you will learn new things, hopefully, as more research comes out, or as new crises kind of were presented with new issues in our community. I'm sure the pandemic taught us all that. So yeah, hopefully that answers your question. Any other things that I can answer?
Thank you everyone for the questions and for engaging today. And thank you so much, Dr. Choy-Brown, for this great presentation. As I mentioned, we will send out a copy of the PowerPoint presentation with all of this rich information. And for those of you interested in a CEU, you will get one after completing the evaluation as well within the next week or two. So again, any other questions, feel free to email Mimi, and always email Cashew with any additional feedback or questions as well. Thanks again. Thank you, everybody.